Hi, my name is Shaheenah Dawood and I'm a consultant medical oncologist here in the United Arab Emirates, and I'm joined by Professor Stephen Johnston all the way from the United Kingdom. Stephen, congratulations on presenting the Monarch-E overall survival data at ESMO this year. But I thought I'd backtrack a little bit and talk about why did we need a CDK4/6 inhibitor in the adjuvant setting? We saw that it had improved progression-free survival and overall survival in the metastatic setting. Why did we take it to the early stage setting?
I think in oncology, whenever we find therapies that improve outcomes in metastatic disease, it's logical to try and test them in early breast cancer to see if you can stop the metastatic recurrences that ultimately will lead to patients succumbing and dying from their breast cancer. So the key challenge was whether, yes, it improves outcomes in advanced disease, could you translate that into early breast cancer, particularly those patients that are relapsing in the first few years on their endocrine therapy. Because by and large, these drugs work to overcome the resistance pathways that drive the cell cycle. So it was logical to see if you could stop those early progressions in the first few years. And that's why these trials were designed, particularly looking at high-risk patients, to see if adding the therapies could stop those early recurrences, prevent metastatic disease, and ultimately had an incremental improvement in survival.
So that brings me to my next question. Taking something into the early stage setting, as you said, is for those high-risk patients who are likely to relapse. But it's been very difficult for physicians, especially in the community, to try and determine who are those high-risk patients. How can we make it simple for them?
Sure. So I think understanding the features that cause an increased risk of recurrence is important. And I divide them into two features, either anatomical features from the staging or biological features from the aggressiveness of the cancer. And from a lot of historical data, when we designed the trial 10 years ago, it was clear that nodal burden is important. 4 or more nodes dramatically increases your risk. But if 1 to 3 nodes are involved, you need an additional factor on top to really increase that risk of recurrence. And that primarily relates to the grade of the cancer, as well as also tumor size. So those are the characteristics we chose in Monarch-E to be purely anatomical, clinical pathological features that you can determine in your MDTs every week. Biology is also important, so we looked at those tumors that were highly proliferating to see if that was a separate group that would also be at increased risk of recurrence, because that's been shown taking oncotype data, taking proliferation data to show that those are features that are important as well.
So let me ask you a question that's commonly asked in the community. You have a patient with 1 to 3 positive lymph nodes, say a 5 centimeter tumor grade 3, so that would fit nicely into Monarch-E. However, when you do oncotype, because this patient is postmenopausal, the risk recurrence score comes back as say 2.
Yep.
So the question is, does that patient actually need adjuvant abemaciclib?
So we've addressed this question in the translational research that we've done within the trial, and we've done an oncotype assessment in all of the tumors. And whether the oncotype be high, more than 26, or low, we can clearly see that there is still benefit from abemaciclib regardless of the proliferation of the tumor. We've looked in more detail at a sort of continuous scale of Ki-67 as well, and shown that the very low proliferating tumors get the same degree of benefit. So it is not purely driven by the oncotype score. It's a component of risk, but it's not the sole component of risk. It's a predictive factor, but a prognostic factor, but not a predictive factor for benefit.
So I always maintain that oncotype, when you're doing it, you're trying to look to see if a patient requires chemotherapy or not.
Correct.
It doesn't really tell you the benefit from using an adjuvant CDK4/6 inhibitor. Would that be correct?
Yes, and I think for those larger tumors that you cited, more than 5 centimeters, sometimes those are the lobular cancers. They may be the grade 2s. They get in based on size and some nodal involvement, and they are often very hormone dependent, not very chemosensitive, but still can have hormone resistance pathways that can be overcome from a CDK inhibitor. The direct comparisons of chemo versus CDK inhibitors are in ongoing trials, but I think this is a question a lot of clinicians will ask. Well, if I can avoid chemotherapy, are they still at risk? Yes, I need to add something different to chemotherapy to improve their benefit.
So now let's deep dive into Monarch-E. Now Monarch-E, as the way you designed it, after patients received their chemotherapy, radiation therapy, surgery, they were randomized to get 2 years of abema plus their endocrine therapy versus endocrine therapy alone. Now this year at ESMO, you showed us the 7-year follow-up of the cohort of patients enrolled in Monarch-E, and there seemed to be a sustained benefit in terms of IDFS long-term. Were you surprised to see this post 2 years of completion of abemaciclib, or was the community surprised to see this because it was only 2 years of abemaciclib?
Yeah, I think what's important when you look back over the last few years of the data analyses that we've done in the trials, to pick up two things. Firstly, 2 years is sufficient to cause the curves to separate and continue to separate out to 5 years. This is the so-called carryover effect we've seen with endocrine treatment before. So a period of treatment provides benefit well beyond completion of the treatment. The key thing is when that then continues to separate or maintain. And what we've shown in the new data is that between years 5 and 7, that difference is maintained. So that means a cohort of patients have almost certainly had their recurrences prevented, and that cohort is big enough to hopefully then drive an improvement in overall survival that we've seen. But if the curves continue to stay apart, then the impact has been on those early recurrences in the first 5 years.
Does the separation of the curves and the fact that now we're starting to see it sort of plateau, does that tell us that perhaps we needed to use a longer duration of CDK4/6 inhibitor to say 5 years rather than 2 years? Because that was an arbitrary decision to use 2 years.
It was an arbitrary decision that was both clinical and scientific, that we thought if you're going to impact on micrometastatic disease, particularly proliferating cells in these high-risk tumours, it's a period of time after they've had their chemotherapy that's important. I think the issue about longer versus shorter is not going to be answered at the moment. Another trial has looked at 3 years versus no treatment, but I don't think people are going to really want to take these treatments for very long periods of time. We know in the metastatic disease you can take them safely, but those patients have got metastatic disease remaining in remission. In the curative setting, the additional toxicities, both clinical as well as financial, mean that I think a period of treatment is what is required to impact on that cohort that are going to relapse early.
So now let's look at the fact that you've shown a statistically significant overall survival benefit. It took some time to show that benefit. Sure. Why do you think it's taken that much amount of time? Although I feel that it's shorter than what we've seen in other trials, but still it took some time. Why do you think that was?
I think improving overall survival in hormone-positive breast cancer has been a challenge, and I in the introduction provided some background about what we find with aromatase inhibitors compared to tamoxifen. Yes. It took the meta-analysis of a significant number of trials and patients followed up for a long period of time to show a 2% improvement in overall survival for aromatase inhibitors over tamoxifen. Indeed, extended therapy with aromatase inhibitors to 10 years versus 5 years does not actually improve overall survival. So I think it takes time to see this, because when patients do relapse, they have treatments for their metastatic disease. And we know that these cohort of patients can live with metastatic disease for numbers of years. So to impact on overall survival is not only a challenge, but you have to wait. And for one trial in 5,500 patients at 7 years to show a statistical improvement in overall survival is pretty unprecedented in hormone-positive breast cancer. We haven't seen that for over 2 decades. So I think that tells you that in these higher risk patients, if you impact and prevent metastatic disease in a significant number of them, that will translate into fewer patients dying overall.
Absolutely. So I actually did a few computations, and please correct me if I'm wrong. No? So according to your study, there was a 1.8% benefit in overall survival at 7 years. Now, if I'm computing this correctly, you need to treat 55 patients for 2 years with 2 years of abemaciclib to save that one patient at 7 years. Is this correct?
I think these are the numbers needed to treat, and you can do similar calculations for the numbers needed to treat to prevent one recurrence. And I think these are important discussions often in regulatory authorities, health authorities, as to whether that is important. And the costs that are calculated are the treatment of metastatic disease, which is expensive. If you reduce that cost, that can be cost effective. I think if you can look back at all the treatments we've introduced for breast cancer, if you look at chemotherapy versus no chemotherapy, it produces a small incremental improvement in survival. You look at the HER2-directed antibodies, again, small incremental improvements in overall survival. Treatment to no treatment has a big impact on overall survival. And then the incremental changes are, yes, more treatments that come in are more expensive, but you have to do that calculation as if you can save more metastatic disease and ultimately save more lives, is that a cost society wishes to pay to improve outcomes in a cancer condition? And by and large, that is considered effective use of money.
Absolutely. Everything is additive at the end of the day. So when I look at the curves, they're obviously overlapping for a very long period of time, which is the overall survival curves that I'm talking about before that separation and that statistically significant 1.8% benefit. Now, the way I tried to explain it was actually the data that you showed on their post-relapse therapy. And almost 50% of the patients in the endocrine therapy alone arm went on to receive CDK4/6 inhibitor. Could this be the reason why we didn't see an earlier separation in the Kaplan-Meier curves for the overall survival?
So we were very keen to look at treatments post-progression because if there was any major imbalance, that could drive differences in the survival curves. And we know that CDK inhibitors in metastatic disease improve overall survival. So if one arm was getting more than the other, could that impact it? Now, what it would be if the endocrine therapy alone arm was getting more CDK inhibitors, that could overall diminish the overall survival curve.
Absolutely.
So if there was exact equality in treatments, the survival benefit may be different. The problem here is you cannot prescribe what clinicians in a multi-center trial globally, how they are going to treat the patients. So we were keen to look into when that difference occurred, and that difference occurred in those who relapsed early, within the first 2 years or 1 year after their abemaciclib. So in the first 3 years, where patients on the endocrine therapy alone arm who'd missed out on a CDK inhibitor were more likely to get it. And those patients who relapsed on their adjuvant CDK inhibitor or shortly after were more likely to get chemotherapy. When we looked at the later progressions, it was much more balanced as to what the patients were receiving. And that makes clinical sense that perhaps that was the way clinicians were treating their patients. But you cannot pre-prescribe the treatment that everyone's going to get in the metastatic setting. And it becomes a study in itself to then look at all the individual treatments and the sequences they have and what impact they have in survival. But understanding any imbalances is, I think, the initial thing to look at to see, could this difference have been driven by more treatment in one arm versus another? And the way it panned out with CDK inhibitors, if anything, if we didn't have that, it could have been a bigger difference in the overall survival curve.
What I noticed from the post-relapse therapies that patients were receiving, in the endocrine therapy alone arm, there was only about half of the patients that actually went on to get a CDK4/6 inhibitor. Were you surprised by that? I mean, it's an established standard of care, 100% should have received it. Why did that not happen?
I think 2 or 3 reasons. At the moment, this is data we're collecting in real time still. So some patients, we've not been able to fully get all the information. It wasn't a protocol-defined analysis. And the second thing is there are countries in the world where these treatments are not funded or available. There are even Western countries where you get a CDK inhibitor once, either in the adjuvant or the metastatic setting. So differences in availability in different countries, together with the challenges of data collection post the study, mean that data is, to a large extent, totally, it's a snapshot, but it's incomplete data.
Okay. Now, when I looked at the table that you presented in terms of the types of distant relapses that were happening, it seems like, of course, there were more distant relapses happening in the endocrine therapy alone arm versus the abema arm, but the types of relapses were different in terms of who was getting bone disease versus visceral disease in the liver. Can you shed some light on that? Because it seemed to me like the patients that were relapsing on abema might have had more aggressive disease.
Well, I think the biggest difference was in bone and liver metastases, and those are the most common sites of recurrence in ER-positive breast cancer. And in high-risk ER-positive breast cancer, perhaps we see more visceral disease. So I think it wasn't that surprising to see those differences. I think the patients that relapse early despite a CDK inhibitor have inherently a very different biology to the patients that relapse later. And that's what we're looking at in trying to collect as many biopsies from patients who relapse to look at the biology of those early recurrences on either therapy versus those later recurrences. Because undoubtedly, although anatomical staging may be fairly similar between the two arms, biological features might drive early versus later recurrences. And that, I think, is work and research that needs to continue to actually really refine our treatment options for these patients.
I'm sure you've seen the recent publication that came out in ESMO Open of a cohort of patients who had relapsed on adjuvant abemaciclib, and what they essentially found was in the relapse biopsy samples that a good proportion of these patients had actually lost ER expression. Could that be the reason for the perhaps more aggressive biology that we as community oncologists are actually seeing on the ground?
It could be. I mean, we allowed patients that had any quantitative level of ER into the trial, and again, a step analysis has shown benefit is there regardless of low versus high ER. But ultimately, we know from intrinsic subtyping that if you have more of a basal type luminal breast cancer, which is manifest by very low ERs, it's verging into the more triple negative biology of breast cancer. And those may be a group of patients where benefit is not seen. We're also doing a lot of in-depth analysis to the different key mutations. The most common mutation in breast cancer, PIK3CA, does not appear to be a resistance mechanism, but a predictor of earlier recurrence.
Okay.
c-Myc amplification may be a marker of relative resistance to CDK inhibitors, and we're doing a bigger study to try and address that. RB loss is very uncommon, but again could be another resistance mechanism. So there's probably a very small group of biology-driven tumours that are inherently resistant to CDK-based inhibitor therapies. Whether ultimately we'll be able to type all up our primary tumours and select those patients out, we don't know, because what we've got to then find is better treatments for those patients.
So you had almost 43% of patients in the abema arm that actually received chemotherapy as their first-line therapy post-recurrence. Why is that? Again, trying to get back to the fact that do they have a more aggressive biology? And these were in the early recurrence patients.
These were the patients relapsing within the first 3 years, so either on their abema or a year after. And it was undoubtedly, it was a physician's choice to then treat those patients. So I think if they were relapsing on their abemaciclib and had liver metastases, I think clinicians would say the likelihood of a further endocrine targeted treatment working here is low. I'm going to give these patients chemotherapy. What we'd love to understand is how well those patients did on their chemotherapy. Were they actually resistant? Was it a large lobular cancer that in actual fact had a PIK3CA mutation and would have been better with a targeted PI3 kinase inhibitor? The usage of those targeted therapies was very low in both arms, again due to global availability, because the trial was recruiting 2017 to 2019 before these drugs were approved. So here, gone 10 years on from when we designed the trial, the number of therapeutic options that patients have in the metastatic setting has changed dramatically.
Of course.
But hitherto, clinicians would have thought an early recurrence, I have to use chemotherapy.
All right. I've always maintained that in patients with early stage breast cancer, ER/PR positive, HER2 negative, with high-risk features, you have to optimize first on your endocrine therapy before you go on to CDK4/6. Now, one of the factors about monarchE was that you did allow patients to not receive GnRH analog if they were premenopausal, and tamoxifen was also allowed. Now, what I found fascinating about the results that have been published so far is that even in those patients who got a combination of abema plus tamoxifen, they did as well, if not better, than the patients who were getting an aromatase inhibitor. So does this give us the flexibility to combine CDK4/6 with tamoxifen, especially those premenopausal women who can't tolerate an AI?
I think the short answer is yes, it does. The more complicated answer is the data that are published are the first hormone treatment that the patients received. And if I'm treating a lady in her early 30s with chemotherapy for their ER-positive breast cancer, they may go into a temporary menopause from their chemotherapy. But if I put them straight onto an aromatase inhibitor without a GnRH agonist, we know that we can fire up ovarian function again. So it is safer to use tamoxifen in those patients, assess menopausal status, and when you know that they're truly postmenopausal 18, 24 months later, convert them to an aromatase inhibitor. So you'll probably find that the vast majority of patients in the trial were actually rendered menopausal by their chemotherapy, and that the vast majority transitioned through a switch strategy of an tamoxifen to an aromatase inhibitor. Other trials have mandated that everybody must have an LHRH agonist plus an aromatase inhibitor, but for some women in their early 30s, that is very harsh endocrine treatment in terms of toxicity. So I think the flexibility to have tamoxifen in there is an important pragmatic clinical decision we took in the design of the trial that I think is helpful to clinicians. But remember, you will be transitioning these patients who are at high risk by and large through into the menopause and onto an aromatase inhibitor and onto extended duration of therapy.
So that takes me on very nicely to my next question. Do we need extended endocrine therapy if we're going to give adjuvant CDK4/6 inhibitor?
So again, in the trial, it's clinician's choice, but because these are high-risk node-positive patients, by and large, most people are going on. And the data we have so far is that over 90% that have gone through 5 years are still on their endocrine-based therapy. I think the issue here is, would CDK inhibitors replace extended duration? No, I don't think so, for two reasons. One, I think extended duration is more about preventing later recurrences. And what we don't know yet is whether CDK inhibitors affect dormant cells and prevent late recurrence. My inherent thinking is that they're going to be much more likely to prevent the earlier recurrences from the active disease, because dormancy is a completely different biology. And that's probably where extended adjuvant therapy helps, by delaying the later recurrences, as well as preventing second primary cancers. So no, I don't think it would replace that strategy.
Okay. Now let's shift gears a little bit to Natalie. That was also presented at ESMO. They presented their 5-year update. These were patients that had more intermediate as well as high risk, randomized to get 3 years of ribo plus endocrine therapy versus endocrine therapy alone. Now, what I found particularly fascinating about their data was that they showed a statistically significant benefit in the node-negative cohort in terms of the IDFS benefit. What are your thoughts about that?
So I think a lot of us have watched that node-negative high-risk group with interest. And I think they did identify high-risk node-negative patients. There's no doubt about that, because on the 4-year data we saw in the control arm, 13% had relapsed on endocrine therapy alone. And it's important that clinicians realize that these are high-risk node-negative patients, and real-world data has also shown that a high-risk node-negative patient has the same risk of recurrence as an N1 patient. So it's either based on tumor size, grade, or if grade 2, high genomic features and so on. And that only represents around about 12-13% of all node-negative patients. So this is not a therapy to stretch into all node-negative disease, it's to select the high-risk node-negative patients. Now the 5-year data do show ongoing benefit in the node-negative patients, a delta of over 5% in that group. It is only a small cohort of the overall trial. It's only around about 15-17%. And sometimes the powering for individual subgroups, you have to be careful about over-interpreting that. And although the upper confidence interval dropped below 1, they're not specifically powered to have benefit statistically proven in that subgroup. And the number of events is still very, very low. Yet the trend is very encouraging. So I think the trial has clearly demonstrated CDK inhibitor benefit beyond the very high-risk node-positive patients into potentially all node-positive patients as well as high-risk node-negatives.
So when I looked at their overall survival curves, you do begin to start to now see a separation, although not statistically significant. Looks very similar to what we're seeing in Monarch-E, which makes me think that with additional follow-up, that is probably going to separate even more. Does this give at least the community more confidence that now you've got 2 trials that are showing very similar data and we should be implementing adjuvant CDK4/6?
Yes, I think the discussant at ESMO made that point very clear in that she said, look, CDK inhibitors are here to stay. 2 trials with evolving data that's continuing to show benefit tells you that this class of treatment clearly works in the early breast cancer setting. The Natalie data are about 2 years behind Monarch-E, so their 5-year data are very similar to what the Monarch-E data were at 5 years as well. Their event rate is lower because they've got a broader risk patient population, so they may have to see more events in terms of overall survival to meet statistical significance. But the separation of the curves looks encouraging at this early point. and they have committed to continuing to follow up the trial for another 4 years, as we have with Monarchy as well. So both trials will continue to collect data, but this was a landmark analysis in both trials at the 5 years for Natalie, 7 years for Monarchy, really establishing these as standard of care for these group of patients.
No, absolutely. So now let's go on to some practical questions. The first is, when you're giving a CDK4/6 inhibitor to a patient who's got metastatic breast cancer, it's very different from giving it to a patient who's gone through chemo and radiation therapy and surgery, and they're tired and it's just been such a long journey. It's sometimes very difficult to get patients to comprehend and understand that they need additional therapy, expensive therapy, and therapy that's going to go on for a while. How do you manage it in those sorts of patients? How do you get them to sort of adhere to their medications?
So I think you raise perhaps the most important point, both for clinicians as well as patients, to understand the importance of the treatment, and also for the adverse event profile to be properly explained and patients taken through it. You're absolutely right that the cohort of patients is different both physically and mentally. In metastatic disease, patients by and large haven't been on the treatment for a period of time, and they're devastated by the recurrence of their metastatic disease and they want to do something about it. In the early breast cancer, they're exhausted because the vast majority have gone through chemotherapy. They've got no evidence of disease, yet somebody tells them that they've got a high risk. So mentally, they're in a very different space. I think the key thing is at the tumour board meeting initially to identify in the patient's summary notes that they are indicated for this treatment because they fulfill the criteria. So that when the oncologist first meets the patient, they're saying, we know that this is the type of cancer you've got, this is your risk, we've got each of these treatments. We're going to start with chemotherapy, you then need some radiation treatment, you'll need some hair hormone and another drug. But we'll leave that and come back to that at a later stage. But they already know about it. I think if you spring it upon a patient when they've just done their chemo and their radiation, they're ready to get their lives back, and you say, oh, by the way, there's another treatment you need, that's when you have problems in getting the engagement of the patients. So I think it's meeting expectations early, parking the discussion until you're ready to do it in detail, but knowing that that is going to be coming as part of their therapy, and then a detailed discussion about the adverse events, how to manage them in the first 1 or 2 months. Because by the time you get them to pass that stage, adherence is good.
Absolutely, and I always say don't start too early. Once they finish their radiation, you need to give them time to recover before you start that CDK4/6.
And you have about 3 months with the abemaciclib to do that. They can have started their endocrine-based treatment, and I often will, particularly in a premenopausal patient, make sure they're settled on ovarian suppression if we're using that, make sure they're covered over their side effects of chemo and radiation, and then introduce their CDK inhibitor. Because I think there's a mistake made by rushing it all too much. That's when compliance is going to be difficult and you'll lose the patient to treatment.
Absolutely. Another practical question is, in our part of the world, a lot of these women are high risk. A lot of these women are premenopausal and they haven't completed their family. This year at ESMO, we saw the results of the positive study, which told us they could potentially take a break, have their children, and then get back on therapy. Problem is that entire study did not include patients who were getting CDK4/6 inhibitors. So my first question is, when can they take that break? And two, how much time do they have to wait after completing the CDK4/6 inhibitor before it's safe to actually have a baby at that point?
Well, I think positive waited by and large until people were 2 to 3 years on from their therapy, and that would fit very well with the period of time that people are on abemaciclib. The drug would clear relatively quickly. The bigger issue is getting patients back into a regular cycle, and that normally takes a minimum of 6 months or so for patients who've come off their tamoxifen, or if they've been on OFS, for them to get a cycle back. And your CDK inhibitor will have cleared by then. I think the bigger challenge is the level of risk that patient has. If you've got a patient with 10 involved lymph nodes and a large grade 3 cancer, yes, we've improved their outcome, but they're still at risk. And that's a wider moral and ethical discussion with a woman as to whether or not this is her first precious child she's trying to have, or it's her third, as to where she is in her cycle. And again, you can't make that decision with a patient at diagnosis. You wait, you let it evolve, and then people have that discussion. But if they are keen to have, and we know that subsequent pregnancy is safe, then at least 2 years, and then another 6 months, I think, until a cycle clears.
Which is a very practical way of actually approaching it. So another practical question that community oncologists will now face: those patients on adjuvant CDK4/6 who are going to relapse. How do they approach such patients? Because in the past, patient has recurrence of disease, it's CDK4/6 inhibitor first-line therapy, irrespective of early or late recurrence. Now we've got the added complexity that the majority of these patients would have received it in the adjuvant setting.
So this is where we're redefining what the sort of algorithm for treatment of metastatic disease is going to be. And I think it will be using essentially an ad hoc definition of CDK inhibitor resistance, which is relapsing during or within the first year. We don't have proven data that you can re-challenge at exactly 1 year or whatever, but clinicians would by and large re-challenge if it was more than a year off treatment. I think you will probably follow the pathway as you would do as if you'd use the CDK inhibitor in metastatic disease. Your genotype the tumor at recurrence, so they've got a PIK3CA or an ESR1 mutation. We've got a whole host now of second-line options. The field has become incredibly crowded in this area of oral SERDs and various PI3 kinase, AKT inhibitors, mTOR inhibitors have had a resurgence since ESMO as well. So I think you would treat those patients as CDK treated, and therefore I follow the algorithm of what to do post-CDK inhibitors, of which there is a sort of plethora of options now. So I think it's not a reason to deny the patient's treatment in the early breast cancer setting, because they're likely to still derive some benefit. But if they relapse early on their treatment, then they're into already a fairly endocrine resistant scenario, and you just follow the algorithm of how we do it in metastatic disease.
So do you believe that the definition of endocrine sensitivity and resistance now needs to be changed based on the fact that not only are we using adjuvant CDK4/6 inhibitors and we have to think about their relapses in terms of their DFS, but also the fact that we have other studies that are coming and looking at biomarkers to be able to define resistance and sensitivity?
I think it is something that's going to evolve. The ABC 8 meeting next week in Lisbon, which derived the endocrine sensitivity guidelines that ESMO has adopted, I think is going to start to look at this, because it's not just the clinical features, which is what we've had before, it's integrating the biological features. And their last version of did start to integrate those features, certainly for PIK3CA and ESR1, which are the common mutations that we assess. So I think it will become a more complicated algorithm and definition of resistance that will incorporate not necessarily CDK inhibitor resistance, but the biomarkers that are driving the resistance, which will predominantly be the PIK3CA pathway and the ESR1 pathway.
And then finally, 2 CDK4/6 inhibitor trials, Natalie and Monarchy, both showing we should use a CDK4/6 inhibitor in the adjuvant setting. However, patients are still relapsing. We're not getting 100% cure.
Sure.
What do you see the future being like in terms of trying to improve upon using a CDK4/6?
So I think 2 things are going to make a difference to stop those ongoing recurrences. One might be ultimately the integration of ctDNA monitoring, because that will be a tool that we could use to identify early recurrences and make an intervention. Although there's enormous complexity in this in terms of the assay types and the trials that are trying to make some form of intervention. And the second thing will be better endocrine therapy backbones and aromatase inhibitors and tamoxifen, and that's the oral SERDs, and that's their integration into the early breast cancer space. And here there are trials, 5 trials at the moment, that are looking at this, 2 head-to-heads right up front, with or without a cohort having CDK inhibitors. And then what I think are the more promising trials, which are the switch strategies, 3, 4, 5 years down the line, changing, and that's to pick up the ESR1 mutation. So I think the corollary of these with the 3 main inhibitors that are being tested in the switch strategy will be really important. And that could pick up the medium term to late recurrences. Whether ultimately integrating triplet-based therapy right up front, that's another strategy that we've seen in metastatic disease, CDK inhibitor, endocrine treatment, plus a PI3 kinase inhibitor. That has to be tested in the early breast cancer setting, because these inherent PIK3CA mutations are truncal mutations that are there in the tumor from the outset. They're in about 30-40% of these tumors, and they are predictors for shorter time to recurrence. So I think we'll see triplet therapy coming into the adjuvant space in trial designs for the very high risk biologically driven resistant tumours. So there's a lot still to do.
It looks like the space is going to expand and get more complicated in the future, but all to benefit our patients.
Correct.
So thank you very much. This has been an awesome conversation with the one and only Stephen Johnston from the UK. Thank you.
Thank you very much.